Thank you for joining us for this session of the ASNC interview series. We're very excited to have with us today Dr. Kim Williams, who is the chair of the Department of Medicine at the University of Louisville. My name is Dr. Renée Bullock-Palmer, and I'm here with Dr. Brittany Weber. Welcome, Dr. Williams. I'm so thankful that you could join us today.
Thanks for having me.
Okay, great. So I'd like to start with the first question. So how has your interpretation of SPECT myocardial perfusion studies changed over the many years that you've been doing these studies?
That's a really good question. I actually started off very early being very quantitative and not necessarily accepting the software interpretation. And I early on tried to fall into the use of databases. And many of the vendors won't like the fact that I say out loud that they didn't always fit the population that I was serving. And so first we started doing our own databases, and then we realized that unless you have gotten into doing stress only with attenuation correction, you have the data that you need, particularly someone who has not had a myocardial infarction. The baseline is actually their resting study, or if back in the old days, the redistribution study. And so why not spend a good amount of time quantitating the pre and post? That kind of intervention study will actually give you the information that you need to know about what's changing, because that's really the crux of the issue. And of course, obviously that was tough in the old days because we weren't always using attenuation correction. And we were actually trying to ferret out what's a scar and what's attenuation artifact. Anterior wall in women, inferior wall in men were typical. And then the good news is gated SPECT came out. And gated SPECT, if you looked at it, came out with Fourier transformation. And if people are not paying attention to the Fourier transformation, you're sort of losing a little bit of information that I think is probably the most important thing in nuclear cardiology. That is distinguishing the scar from attenuation based on the motion characteristics. Is it thickening? Does it have good amplitude? And does it have normal phase? That's it contracting in phase with the rest of it. That means that it is an attenuation artifact and it is not likely to be a scar. So anyway, over the years, I've been employing those tools. It's been quite a long time since I started that, and I've kept it up over the decades. I would say that the one thing that I teach and do clinically that most people don't is I take those two images and I quantitate pixels. And you can always do that by raising your baseline and pulling down the top window until it's down to black and white. And when something turns from black to white, that number that you're seeing on your screen is the number of pixels. And then you can compare. And so when people say, oh, it was a 10% change or it was a 25% change, and we use those to determine if it's less than a 10% change, you're probably not going to do very well in calling it anything. 10 to 25% you'd call a reduction with stress compared to rest. You would call mild ischemia. 25 to 50, you would call moderate. If it's less than 50, pretty much everyone would say that is severe unless it's absent. And absent would be a couple of different definitions. One is equal to background. The other one would be that it's actually, that you don't actually see any counts in the wall. And so either way, and that would set up your, 0, 1, 2, 3, 4 scale that you can then use to come up with a sum stress score and then compare that with resting, get a sum difference score and a percent myocardial ischemia. And I'm hoping at this point that everyone is adopting that same kind of algorithm, but it's hard to do that visually. You really need to count your pixels.
Thank you so much, Dr. Williams. I'll turn things over to Dr. Weber to ask the next question.
Thank you. And I'd also just like to thank you for being here with us today. And so in the interpretation of your studies, Dr. Williams, do you look at the clinical features of the patient as well as the other stress parameters first, prior to looking at the SPECT study and the interpretation of your studies? And kind of going along that, what is your systematic method for interpreting every study?
So it's interesting that when I am reading with fellows, they will always tell me the info, oh, this is a 60-year-old man, he's got chest pain. And back in the day when we were doing a lot of Bayesian analysis, you really wanted to know the pretest probability at some point during the interpretation so that you would take your findings and put them in the context. The problem with that is that it moves your receiver operating characteristics if you're saying, oh my gosh, this is a 75-year-old man with who's sent because of a coronary calcium score of 2,000, and he's having chest pain, and I saw that there was SC segment depression, then that attenuation artifact with maybe a subtle difference is likely to be read as ischemia. And so no, I actually kind of try to make sure that we are going to be so objective and counting the pixels, as I mentioned in the first answer, is so objective that any subjective information doesn't change how you evaluate the study. Now, obviously, in many situations, particularly in cardiology, where, let's face it, the nuclear scan is supposed to be kind of like a consult. And we're not getting paid necessarily for the consult, but people want to know, what would you as a cardiovascular practitioner do with this information? And they want a risk line, that's risk assessment, or, what's the next step? And a lot of that doesn't go into the report. It's on that phone call. Hey, this is a high risk study. It's got transient ischemic dilation of the ventricle. The drop in ejection fraction has some different score of, 14, which is translating into a sizable reversible ischemia index. And so you probably want to move on to the next step if this is, is going to be invasive. And so that sort of stuff happens with the phone call that we, back in the, ASNC quality days, we're always talking about making sure that you call the referring physician. And that's where you really take into account what the clinical situation is. But I would say that to get your best results out of nuclear, the findings have to stay on their own, have to stand on their own.
Great. So that was a really good discussion of the first two questions. So having said that, could you walk us through the interpretation of one of your studies that you may have in your lab? What are some of the important points that nuclear cardiologists should include when reporting these studies?
So I've gone through different phases. I have a little disclaimer here is I'm a recovering nuclear cardiologist. As you know, I probably know, well, no, there's no reason you would know this, but the methodology section of the radionuclide imaging guidelines from 2003, ACC-AHA, I actually wrote that. And so I was very particular about it. But then I became a division chief a decade later, and then I became a department chair. It's kind of like I'm so far away from it at this point. But so with that disclaimer, I will tell you what I think should be the sequence of events. And I would say that if the software will allow it, the first thing you do is the quality control. And so if you're talking about PET or SPECT, you really want to make sure that you're not facing a lot of artifacts. When is a humorous not funny? When it's down and getting in the way. And then it's even more not funny if it's different in a different location between rest and stress. So you really need to inspect your raw data and your reconstructed data for quality issues. And most systems have some motion correction for SPECT and even for PET. PET, it seems to work pretty well. A lot of the x-axis corrections for SPECT can be actually destructive as opposed to y-axis, which seems to work pretty well. But I'm always concerned if the motion artifact motion corrected study has abnormalities that you don't see on the uncorrected data, that you've actually induced something. So anyway, quality is important. And however you do that, sinograms, linograms, whatever you need to do to make sure that you've got good studies. Now, the funny part about it is that all needs to happen. When I was a nuclear lab director from 1986 to 2012, I would kind of be the toughest audience and I would want the techs to go over the data really carefully. And if I had a relatively new technologist, I would go through the data personally before the patient leaves. Because if there are uncorrectable motion artifacts or something that is really poor, a lot of GI activity, the worst part was once we had all these wonderful agents, which are hepatobiliary, and you'd get someone with a little bit of ileogastric reflux and a little gastroesophageal reflux. And the next thing you know, what should have stayed in the gallbladder ends up in the esophagus behind the heart, and you end up with negative lobe artifacts or ramp filter artifacts. So it's really important to make sure that someone with a lot of knowledgeability is checking on those studies before the patient actually leaves, so you could do whatever it is you need to do to get a quality acquisition. Okay, once you determine that you have quality, then I know it goes out of order compared to a lot of places. I actually like to look at the gated images first. There you can see that if there are some major artifacts, gating artifacts that mean that you really should be looking at a resting study in its ungated fashion. And a lot of our systems nowadays will do the resting study gate or do a gated acquisition, but also have a second bin that allows you to take an ungated acquisition simultaneously. So that if there are a lot of PVCs or something like that, you don't end up with more of a systolic frame or more of a diastolic frame when you add all the data, because those are completely different. Systolic frames have a smaller chamber, and the partial volume effects means that the defects get smaller with the myocardium getting thicker. And the diastolic frames have more attenuation artifact. Why? Because the chamber's got blood in it. And so these images are completely different. You have to have the entire cycle at rest and stress and compare the entire cycle. So now that if you don't have a system that has ungated plus gated acquisition simultaneously, you probably should look into that to make sure that you're not getting some artifacts. Okay, so you're looking at the gated, you're looking at ejection fraction changes, you're looking at chamber size. And so if someone says, oh, the quantitation says that transient ischemic dilation is there, you're seeing that, I go back to those gated images and I look at end systole. And if end systole is really, if the GEF really dropped, end systole is going to be bigger on the stress than it is on the resting. And if I don't see that, I know I've got a problem with some of the quantitation. I have to go back and, redo the borders. And I have to admit if I'm reading 16 studies a day, I might be maybe one where I actually don't change the borders myself, because you want to get exactly that same level of the base inclusion, because that changes the volumes and it changes the ejection fraction. Okay, once I've done all that, I'm going to make sure that with a SPECT CT or PET CT system, that I actually have a good comparison of the two in terms of the Fourier transformation on the attenuation corrected images. And I use that Fourier transformation to look for any changes in phase that occur that would happen with ischemia or infarction. Because I've spent so much time working on the polar maps, okay, and making sure that the limits are set exactly right between the rest and stress, I then can do what I think is the magic of nuclear cardiology, and that is taking those polar maps and doing math. And the simplest approach is the subtraction. And most of the software will call that the reversibility image, where you take your resting study and subtract the stress. And the reason that that's so important is that there's something that I reported years ago, and I always sort of joke about how, the major advances that I've contributed to the literature are largely ignored. This one isn't so funny. It really isn't. And it is the not recognizing a change in the location of the peak pixel count. So you start off with somebody who has multivessel disease, and you do your polar map, and you see that the maximum count is in the anterolateral wall where it normally is at rest, but in stress, it's over on the septal side. Well, the software is programmed to increase the counts on both to the maximum count in the study, not paying attention to the fact that it moved. And so the one thing that you could do quick and easy is look at the reversibility map, because it'll tell you. You're seeing that the images don't look all that different, but there's this huge difference on the reversibility map. That'll tell you that there's been a change in location of peak pixel count. And then I go back and I adjust. And, it may be that I have to, you look at the new peak pixel count, find out how many counts there were at rest, readjust. And that requires sort of a dual image display, which all of the vendors have now. They have a dual translation table. You put one on this, the rest on one, the stress on another, and you raise the top until you represent exactly where your new peak pixel count is, how much counts there were, and what's the intensity that it was at rest. Once those are equalized, then you can actually do a good visual analysis. Hard to quantitate, but and if people really don't want to go through all of that difficulty, which is really important because the study that we did showed and it improved our detection of multivessel disease from 66% up to over 90%. So SPECT normalization, but the same thing is true of PET. Please, if people aren't doing that in your lab and looking for a change in location of peak pixel count, please take a look at it. I should also mention there are other marker for multivessel disease on exercise that doesn't work with farm stress. Is increased activity in the right ventricle at exercise that wasn't there at rest. Another thing that I published that was largely ignored, but we look for that because that tends to be a sign of left main disease. So now we're looking, what I basically have done is categorize for you the high risk markers. And then we do what everyone else is doing, break it up into 17 segments, compare the rest and the stress, and try to come up with some different score that will help populate with your software, dividing it by 68 to come up with the percent myocardial ischemia.
Brittany, next question.
Thank you very much, Dr. Williams. And I'm going to have to reuse that humor stroke. That was hilarious. So piggybacking along this, so do you perform attenuation compensation in all your studies? And so with the interpretation of the nuclear studies, then is the nuclear portion reported separately? And if it is, then should we be discouraging this method?
So now, obviously, there's different ways of doing attenuation correction. I was never very happy with the gadolinium source or anything other than CT. And CT actually works really well, provided that you make sure that they are aligned. And our techs, when I was reading in the nuclear lab at Rush the last month, the techs were actually really good at making sure that they were aligned. I always wanted the software to do a little better job because of allowing the interpreter to adjust things if we needed to. But the fact of the matter was we actually did pretty well because the techs were so good. Occasionally, we had to turn one back in. Okay, so attenuation correction done well is really important. But the question I think you're asking or headed toward has to do with what do you do with that information? I mean, it's if you're doing CT, it's a CT. And there you're going to find that 5.8 centimeter ascending aorta, and you're going to find the coronary calcium. And we actually, when I try to add it up at the end of the day, because I did go through all of the training for CT and board certified in cardiovascular computed tomography, I would think I'm out of the 16, studies per day, maybe 2 wouldn't have any findings on the CT. That's probably an overestimate, no matter think about it. There's something there. And I think anyone who isn't, when people are buying a gamma camera and they're not doing hybrid imaging, they're putting the blinders on their own interpretation and understanding of what's going on with the patient. For example, probably my best realization ever is that how many people order a stress test, a stress nuclear study, rule out coronary disease? That's not what it does. It rules out ischemia. Okay, it evaluates ventricular function too, but it rules out ischemia. Well, how about having a test that rules out coronary disease? And that would be a hybrid study where there's no ischemia to tell you endothelial dysfunction and no coronary calcium. And it doesn't say absolutely that there's not, non-obstructive, uncalcified plaque, but it puts you in a good so-called MESA territory, the power of 0. And you can't do that without the attenuation correction. So what I would say to everyone who's not doing it right now is to talk to your administration. Try to get them to go through their own chest CTs, even the abdominal CTs that have a piece of the chest, and look at the frequency of an abnormality that generates downstream revenue. And, the administration might listen to revenue. As a clinician, I'm thinking that lung nodule would not have been found. And that lung nodule is not just generating revenue, it's generating survival. And so we really should be doing it. I think I think it's our responsibility ethically to do the best job that we can with any test that we're asked to do. And right now, I would say that that's hybrid imaging with SPECT CT and preferably PET CT.
Great, thank you. That was a very a great answer. Incorporated, the newer modalities with CCT, SPECT, and hybrid imaging. So as we wrap up, this afternoon session, briefly, what advice would you give, for early career folks just entering into the field on the interpretation of myocardial SPECT in 2022 and beyond? And also as a follow-up, what advice would you give to trainees that are, studying this field?
So starting with the trainees, I have to say that, the time for the dedicated nuclear cardiologist that does nothing else probably is going away. It's great to be level 3 and board certified, but the people hiring, which as a division chief and now as a department chair, you're always looking for that pluripotential stem cell that can actually plug in a lot of holes. And so you probably, I developed it. I really did go into nuclear cardiology, but I kept my hands in other imaging modalities and in prevention and in hypertension. And so I would say the best thing to do is to pick 2 or 3 things in addition to what you're doing in nuclear. Focus on nuclear. We need the young generation to be dedicated. Like, if you go through that list of, past ASNC presidents, these are people who lived and died over photons. And, people would throw protons at us. Now we want photons. And so we have to make our field as best as we can and continue to develop it. Newer tracers, better hardware, dissemination of quality. Because let's face it, when we go to a university, we get a pretty good nuclear scan and we go out in the community and sometimes they can suffer. So that's what I would say is that let's focus on quality and focus on trying to make the field as best we can. For interpretation, it's really make sure that you're doing it in a systematic way. Make sure you're looking for the high-risk findings and hopefully convince your administration to give you the tools that make nuclear the best, and that would be hybrid imaging.
Great. Thank you so much, Dr. Williams, for your time and sharing your knowledge with all of us. We greatly appreciate your contributions and insight that you have shared with us today. And I'll turn things over to Brittany. She had a few last words to add before we end.
I also just want to thank you. I also, that was my wrap-up question, was the advice to the future generation as a young junior faculty member. So I'd also like to thank you for this time. And truly, we learned so much from you taking the time to do this. So thank you.
Thank you so much for having me.